What's up, everybody? My name is Ryan. I'm with the Upper Cumberland Human Resource Agency, and this is the UC Recovery podcast. Today, I've got my good friend Paul Trivette from Cedar Recovery.
Thank you for calling me a friend, Ryan.
Yeah, we've known each other
A few years now.
And
Think the world of you.
yeah, I think the world of you. Been a great partner with the UC Recovery, and I'm looking forward to our conversation today.
Yeah.
Why don't you start us off by just telling us who Paul is and how you came to Cedar?
Yeah. Oh man. Well, I give the Lord the credit for how I ended up here because my path and the way I got into the work is very non-traditional. So, my father battled addiction all my life, and there was a lot that I didn't even know about or didn't realize. I learned later on my sixth grade trip. He was a chaperone for me and two of my buddies on a school trip, and I'll never forget. We were supposed to go to a chapel service, and he started throwing up and shaking in the bathroom of the hotel. And honestly, I thought he had like a stomach virus. I mean, I was in sixth grade. I really didn't know any better. And he laid in the bed shaking. I really didn't know what I was seeing, because I thought he was sick. But when we came back an hour later, and he was fine. He was going through withdrawals, and I didn't know it. And so, my family dealt with addiction both by what we know and what we didn't know. And so I harbored a lot of hostility towards him. Things got worse. The addiction got worse. He stole a lot of money from my grandfather. Broke into my house. Him and my mother tried to raise me in a Christian home, and try to teach me godly Christian principles. We were churchgoers. We're all these things. From the outside, it looked okay, but on the inside, it was a lot different. And so I wanted to arrest bad people. That's what I wanted to do because my father hurt me so bad. So I said, I'm going to go be a police officer. So I was in law enforcement for 5 years up in Bristol, Tennessee. And I had worked for a state representative named Matthew Hill from Jonesboro for a couple of years on some of his campaigns and all that. And he told me about this group because I said, Matthew, I want to get out of law enforcement. I got 2 kids. It's dangerous. I'm very appreciative of what the police and the sheriff's department do. They have a very dangerous job. And he said, there's an organization that needs somebody to help run it to bring awareness to addiction. And I had a lot of hesitation. I said, I really don't want anything to do with that because of what my father did to me. And then he asked me, have you ever heard of the drug Suboxone? I'm like, oh yeah, I've heard of it. I see it. It's terrible. I arrest people with it and all that. And he said, my understanding is there's some good to it. And I was like, okay, well, I don't see how that's the case, but I trust you, so I'm willing to listen. Got to meet with Dr. Stephen Lloyd, who was a friend of his, and started educating me about the disease of addiction, that was a disorder, that my father truly did not want these things. So I'm still in the police department at this time. It's April or May of 2015. And I get a call to the hospital, and there's a guy that had been going into the hospital and still in patient-controlled analgesia pumps, and those are powerful opiates that are controlled by patients like that have cancer and post-operative pain that need to manage their pain. And one of the nurses chased him out. And they said, man, this guy's been really methodical. He's wore Stericycle material as if he's disposing this. He's moving sharps containers all over the hospital. And they gave me his license plate. And it was my buddy I went to college with. And I show up at his house, and I couldn't believe it. And I'll change his name to protect his anonymity, but I'll say Alan. I'm like, Alan, dude, you been in the hospital? And he said, yeah, man, I'm an administrator in the healthcare system, so I go over there and see patients and stuff. And I said, man, they're saying that you're up here stealing stuff. And he gave me consent to search his car and house and all that. And sure enough, I saw things. So I arrested him. A couple months later, he comes up to me at my wife's church softball game. He gives me a hug and tells me that I saved his life.
Wow.
And he said, he said, Paul, he said, I'm ashamed to tell you I'm taking Suboxone now, but he said, my family has welcomed me back. I'm not having cravings. I relinquished my nursing license. And he said, but my life is in order. And I felt like that was a message.
Yeah.
And so took the leap of faith, started running with a nonprofit called the Tennessee Recovery Coalition that I helped start, and really wanted to advocate for best MAT practices because I had seen what bad looks like. And there's bad in everything, and there's great in everything. And so I got to work on some policies to create licensure for these type of clinics and work with the Medicaid system as they develop policies around paying for it. And then in 2020, Dr. Lloyd calls me and says, hey, man, I'm at Cedar Recovery. Would you like to come work with us? And I love Dr. Lloyd to death. And our CEO, his name is Joe Bond. He has a passion. His father started the first drug courts in Middle Tennessee and has a passion for this. And so took a leap of faith, man. And that was November of 2020, and I'm still here today.
Wow.
And so I give the Lord the credit, but at the end of the day, man, I love what I get to do. And I cannot believe I went from law enforcement to this, and so I'm very thankful for that.
Awesome. So what is it that Cedar Recovery does?
Yeah, so Cedar Recovery, we are an outpatient addiction treatment company. We were started in Mount Juliet in 2015. Our CEO, Joe, as I mentioned earlier, he founded it not just because his father started the first recovery courts, but also because he discovered his mother overdosed. And he was in Mount Juliet, well-educated guy, and really didn't know what to do. And he started looking into his own research and, okay, what is effective treatments for opiate addiction? And he started about using medications like buprenorphine, methadone, naltrexone, all these different things. And methadone at that time especially, and even buprenorphine or Suboxone, had a real kind of shady connotation. But when he was researching, he said, well, it looks like that people that try to do Suboxone treatment just give people medicine for $300 or $400 a month. And they're not doing any counseling, they're not doing therapy, they aren't trying to help these folks. So he wanted to change that. So he said, we're going to start a model that prioritizes therapy and counseling and minimizes kind of the medical visit as being the primary thing, but still providing the care. Right. So he developed that. And so we do today, we have 11 what's called office-based opiate treatment facilities. So patients come in, they see a medical provider, they get mental health assessments, we see if they meet the criteria for addiction, and if so, they're prescribed either buprenorphine, which is commonly known as Suboxone, or naltrexone, or they're given an injection of that. And then they are assigned a therapist, a peer recovery specialist, and they see us weekly, and then as they do better, they get to bi-weekly and monthly. And so, we're treating across Tennessee and Southwest Virginia about 4,000 patients every month. Yeah. We have 2 opioid treatment programs. That is essentially what you would call a methadone program. It's in Knoxville. That's our first one that we opened. We got a certificate of need for that last year. To date, we've had about 430 patients. We've been open less than a year. We have about 800 on our waiting list trying to get in. Methadone treatment is the most regulated form of addiction treatment in the entire country. Inpatient, residential, recovery housing, OBOT, it pales in comparison to the regulations around methadone, which it should be. Mm-hmm. It should be that regulated. Sure. And then our Southwest Virginia facility, they don't have certificates of need there. So we had an existing OBOT, and we applied for a license, and we've opened that there. We've got about 20 patients being open the last month. And so, we try to meet people where they are and love them so much to let them not stay there. Sure. And I'll just tell you, man, I think one of the biggest things for me, the reason why I signed up for this too is, we expect all of our people to approach patients with three things. You're going to love unconditionally, forgive habitually, and you're going to demonstrate mercy. Mm-hmm. There's 2 things that'll get you kicked out of one of our programs. That's selling your medicines or threatening to harm our staff. That's only 2 reasons. If you keep failing, we may say, hey, we need to get you somewhere else. This is just not working for you. We'll do the best we can. But we also follow a 70 times 7 rule. And my father went through 5 inpatient rehabilitations, all abstinence-based, and he didn't make it. I don't know what time is the right time. I don't know if it's somebody's 1st, 7th, 10th, or 100th. but we need to keep giving people shots at this. And so that's our approach at Cedar, and I'm proud of it, and I love what we get to do.
What do you think the biggest misconceptions of medicated assisted treatment are?
There's a lot, and actually the reason that they exist is because of the industry itself or the healthcare practice itself. So I think the number one misconception is you're trading a drug for a drug. Even if that is true, then you have to ask yourself, okay, are you trading an addiction for an addiction? And that is simply, it depends, right? So people equate the medicines that we use as being equal to the substances that somebody's using on the street, like fentanyl or heroin or Oxycontin. They equate Suboxone, methadone, and sometimes naltrexone or Vivitrol, not really, but somewhat to that, saying, hey, all you're doing is just trading a drug for a drug, right? So if that were the case, and I just thought about this last year, and Dr. Lloyd it was kind of an epiphany that I had. If that were the case, then we would retain 100% of our patients, because the vast majority of our patients don't pay a dime for their treatment. It's covered by Medicaid, Medicare. President Trump extended it, mandated in 2020 that the Centers for Medicare and Medicaid Services cover methadone treatment and Suboxone treatment. And so that's why Medicaid and Medicare pay for it now. And there's huge cost savings to the healthcare system when people are engaged in this treatment. That's part of the reason. And so we're lucky to retain 50 to 60% of our patients after 6 months and 45% after a year. So if it was trading a drug for a drug, why would they not just keep coming in and getting a drug like, hey, I got my fix for the day, I'm ready to go? Well, there's two reasons for that. The most important was it's a treatment program. You don't just come in and get medication. When you say, hey, I'm ready for help, you're saying, I'm willing to go through the recovery process. I'm willing to be counseled, have my person, places, and things change, have my social determinants of health change, and all that, right? If you're living in a cesspool and you're living with people that are using these substances around you, why would we not give them a medicine so they don't have cravings? An FDA-approved medication to reduce their cravings so that they can focus on their recovery. Okay? So the second part of that is the medications don't even work the same. Fentanyl is a long-acting opiate. Heroin is not. Oxycontin, morphine, those are not. Suboxone lasts up to 30 hours. Methadone, it ranges from 22 up to 32 hours. It's long-acting, right? They work differently. Can you still get high on them? Yes. For an opiate-naive patient, are you going to get high? More than likely not. I'm sorry, opiate naive. You will for an opiate naive patient, but if you are not opiate naive, like you've been in active addiction, it probably is very low. It's probably just going to suppress your cravings. And so, first off, you couldn't even prescribe Suboxone until 2002, and the federal government limited it to 30 people. So the government inherently created an economy for cash-based practices, because now a doctor could have 30 patients on Suboxone. That's it, right? So why not charge a premium? So then what happens? You get Suboxone clinics saying, hey, come see me, $300 to $500 a month. It looks awfully like the pain clinics. You're coming in, you're getting your drugs, and you're leaving, right? So the industry gave it a lot itself, even with the methadone programs too. We have to own that. But there are groups that even exist in Putnam County today that are asking the community to give them a shot, to say, hey, we're trying to do something different. We're trying to change the face of this. We are trying to show you that we want to help benefit this community and people that have addiction. There are those. I'm going to put Cedar Recovery in that. I'm going to put volunteer behavioral health in that. There's a company called Groups Recover Together that does MAT here. Spiro Health that does MAT here. They're all asking for a shot to say, hey, we do this correctly. Please come see how we do it and see it so that we can break some of that stigma. But those are the two common misconceptions, man, is you're trading a drug for a drug. And I want to give you one more. The second one is that the medicines work the same. The last one is that you're going to be on it the rest of your life. Like you say, hey, you're going to take this. We do not want that. We do not want people on this. If they need to be because it's indicated for them, then that's an option for that person. But by no means do we ever tell anybody, hey, you're going to be on this set of time, or we're going to cap you here, or you're going to be out the rest of your life.
Right.
We want to meet that person where they are and help them get to where they need to be. But our goal is for every person to be free of all substances, whether prescribed or illicit.
Wow. Do you recall how Cedar came to be partners with UCHRA and UC Recovery? Do you remember how that came about?
I do. I do. So honestly, it was with Mark Farley and Michael Miller. That's really how a lot of this started. So Cedar Recovery was looking for space to open an OBOT here. And the UCHRA has property across from Volunteer Behavioral Health that was open for a lease. And so we met with Mark Farley, and he allowed us to lease that space. And honestly, we really just wanted to kind of get more involved in the community. That's that's our mission, is to solve the opioid epidemic and to repair the communities that we serve. And so I ended up having another meeting with Mark and Michael, and then I had the fortunate opportunity to meet you and some other folks at UCHRA, and then slowly we got invited to say, hey, will you be a part of the UC Recovery Project? Would you be a member of this? And so honestly, it's been a relationship that's developed over time, and we've been just so thankful to be a part of it.
Yeah. What do you think is the number one ingredient for a person to be successful in recovery? What do you think that ingredient would be?
So it's hard for me to say that there's one, but I will tell you this: if they are social determinants of health, their housing, transportation, home, all their purpose, that community, I'm going to lump those kind of together. If that is not there, I think they have a very low shot at success. Very low shot. So I think that the person having an environment that allows them to have a shot at recovery is probably the number one thing.
What does successful recovery look like, do you think?
Yeah, so it looks different for each person, but I'd like to give you kind of just some general thoughts on this,
Sure.
And how we would define it. So when we look at addiction, we don't just look at medication, right? Because I've been on Zoloft now for 4 years for my severe anxiety. Mm-hmm. I did not know this. Zoloft is not a controlled substance, but back in April of 2023, I ran out and I'm like, okay, I'll quit taking it. I went through withdrawals. Now that's not withdrawals like opiates or anything, but I had a headache. I felt like I had the flu, and come to find out, it was because I just quit abruptly taking this medicine. So I had a dependence on it. I didn't have an addiction. But what if my behaviors would have said, oh, this guy has addiction? If I would have thought, hey, I need to go steal from my family. Hey, I need to go rob a place. Or, hey, I need to go do this to obtain this, to continue this, right? So when we look at addiction, we say it is continued use despite consequences. What is your behaviors? What is your life like today? And then when you enter recovery, what does it look like? So for a person, it may be, hey, I want to give you an example. We have a person that just recently started treatment with us for alcohol addiction. Great guy. But every day he goes home, he can't stop thinking about drinking. And he drinks a lot. He drinks to the point that he passes out. His marriage is struggling, right? His wife said, if you go and get help and you go to treatment, then we can try to work on this. So for him, it is, hey, I need to stop my use of alcohol, okay? And then I need to start working on my marriage. And then I need to work on my cravings to where I'm not, when I get home, I'm not thinking, hey, I need to go drink. So for him, he's been in our program now for a little over a month. Him and his wife went to a bar to meet friends in downtown Nashville, and he did not have a drink.
Wow.
And his wife called us so proud because he had the ability to say no, because he recognized the consequences of what we're going to come from that, right? And so in our opinion, and when I think you look at the recovery, and when somebody says, hey, I'm in recovery, it is when their behaviors, their desires, their actions are demonstrating that they have insight, judgment, and empathy towards the people around them. They're making good decisions, their behaviors are improving, and they're contributing positively to their workforce, to their family, most importantly, for people that are faithful to their relationship with God, all of those things. And so I think that's what it looks like. It does not look like, hey, you just quit using drugs, because you may still exhibit behaviors that show you're actually not in recovery, and that you are susceptible at any moment to go right back to that drug
Sure.
because you've not developed the coping and the resiliency skills. Your brain, you've not allowed it to heal. So that's the way we define it, is when we start seeing those goals reach, the behaviors are consistent with recovery, with good insight, judgment, and empathy towards others.
Wow. Yeah, you're right. To me, relationships and time, they go hand in hand. You don't recover in a vacuum, and it wasn't an overnight thing to become addicted to something. In my own case, surviving 12 years of Oxycontin addiction, 12 years. So, and now I'm coming up on 12, 13 years of sobriety now. Yeah.
Praise the Lord for that, man.
So it's a process, and you mentioned those social determinants of health, and that can be overwhelming to somebody. Like last night, slept on the street, needles in the arm. But if you can focus on one thing at a time and give it the time and have those relationships, I've been fortunate to visit Cedar and see your peer specialist, and they develop those relationships with the people, and that to me is crucial. What value do you think partnering with something like UC Recovery brings to the Upper Cumberland area?
Oh my gosh! I mean, it. So I have never seen, and I don't know if there's any literature even out there across this country for the project that UC Recovery and UCHRA is doing, to really say, hey, this is this is a community approach. This is an all hands approach. This is a all paths approach, right? Mm-hmm. It is easy for us to compare ourselves to others, to say, hey, why is this person putting a needle in their arm? Or do they not think that they shouldn't do that? Or, hey, I got better because I went through Suboxone, so you need Suboxone. Or I got better because I went through a 30-day inpatient program, and I got better, therefore that's how you can get better, right? Success looks different. UC Recovery is offering every tool to success, what is right for that person. Right. I think the benefit is, and I hope the community realizes this. I don't know if they'll, unless you actually get to see it, I don't know if it'll be as truly appreciated as it can be across all of the Upper Cumberland. So the fact that people, when they call at 1 or 2 or 3 o'clock in the morning and say, hey, I'm ready to get help, and they're met with a peer, that they can get to crisis and get to volunteer if they need to. They can have a medical assessment. They're going to be connected to resources. UC Recovery offers resources, right? Let's keep in mind for a second that I learned skills growing up, right? I learned skills. I learned some healthy skills, and I learned some very unhealthy skills that I've had to work through. There are some people that all they know is unhealthy skills because of how they grew up.
Right.
They only know how to hustle. They only know how to survive in a certain way, right?
Right.
Sometimes it's not rehabilitation. Sometimes it's habilitation.
Yeah.
And UC Recovery is offering that. They're offering, whether you need a service for transportation, housing, food resources, and guess what? Treatment resources. That's the thing I love the most. Yeah. And it's not, hey, Cedar's the way. It's not volunteers the way. It's not other treatment programs are the way. It's there is a way that is right for you. Right?
Yeah.
And so again, I think this model is going to be something that the rest of the country, potentially parts of the world, can replicate. And so I think it's awesome.
That's crazy. You're a chief strategy officer. What does that mean?
Nobody knows what it is. All right.
Right.
So I even had to kind of come up with my own job description. But addiction is ever changing. When I first started into this in late 2015, the major concern was OxyContin and morphine. It transitioned into heroin, and now we're dealing with fentanyl. And I'm not talking about microgram doses of fentanyl. I'm talking we've had patients injecting 3 to 5 grams of fentanyl a day. What would kill probably everybody in this building. So it's changing, right? Well, with that changes the strategy that you have to take that you're offering, because giving people a medicine is not going to get them better. It has to be, what type of programs are you implementing? So we have an intensive outpatient therapy program. You don't have to be on medication for that, right? But it's more intense counseling. It is making sure we have the right physicians, nurse practitioners, counselors in place, that we have the right insurance contracts in place, because we want people to have access. So Medicaid, we take all insurances, Medicaid,
Yes.
Medicare, commercial. We get grant funds, so applying for grants. We're looking for innovative things. Like we got a mobile unit that treats people in the southern part of Tennessee. We're doing MAT in the jails.
Wow.
I've got 2 videos from a sheriff in Giles County and Lawrence County. They're letting us give Suboxone in the jails to reentry for a reentry program, and I've got sheriffs supporting it and say, hey, I see success. You're reducing recidivism. We're seeing very positive things with this, right?
That's great.
So on the strategy side is, what can we do? Here's what I want. I want, number one is, I want to treat a lot of patients. I want to treat, because that means we're helping a lot of people. We are not being successful in an outpatient setting if we're not treating a lot of people, because we do not have enough beds. We do not have enough housing in this entire state to treat everybody that has addiction. Outpatient care allows you to reach the masses, either until they can get the help they need in your facility, or you can get them to an inpatient facility or a bed, right? So it's having the strategies around to provide to a lot of patients, help as many people as possible, having the right insurance contracts in place so that everybody has appropriate coverage, that all of our services are recognized and reimbursed, and then lastly, so that we can be more innovative and help more people.
Wow.
So I'll look at new sites. I'll put us through certificate of need processes to open methadone programs, licensure processes. I get to work across all of our team, the operations, medical, compliance, finance, you name it, and make sure that we're working together. My goal is to be knowledgeable in every aspect of the healthcare that we provide, so that if I'm needed as a resource, I can provide it.
Wow.
That's kind of what my day-to-day looks like.
How many people are you serving at the Cookville office, do you know?
It's been increasing. Right now, it's our 3rd largest facility. We have almost 400 patients.
Wow.
And we just hired an awesome guy last year. His name is Justin Davis. He's been a pastor here in the community. He's a psychiatric mental health nurse practitioner. His wife works for the hospital, and they're a staple in this community. And he's on our team now full time.
Wow.
And he treats people out of for substance use disorders and mental health treatment. Our medical director, his name is Dr. Stuart Ross. He's actually fellowship trained in addiction medicine from the University of North Carolina. And Alicia Ellis, who's another psych nurse practitioner that we have, and our peer recovery specialist, Morgan Jones, and our counselor. Oh my gosh, our counselor's awesome. Her name is Janice Alder. She's awesome. That team right there is probably from if you look at the number of people that we treat, I don't think there's another addiction treatment company in the entire Upper Cumberland that's treating as many people as we are.
Wow.
I think we are your largest addiction treatment provider in all the Upper Cumberland, not just Putnam County. I would say when it's all said and done, we'll probably treat between 500 and 600 patients total out of that facility. Now, keep in mind, we're not doing any methadone. This is solely Suboxone, naltrexone, mental health treatment.
Wow. Back to the CSO, what are you seeing on the horizon in the addiction treatment recovery realm? What can you give us a look in the crystal ball and see what changes or what cool things are on the horizon?
Yeah, so I think first off, there is a injection that I know that's been under research at the FDA that would essentially kind of like block fentanyl cravings and stuff like essentially you would have it would help remove desires to use opiates, right? And now you're talking, that's a game changer, right? Because now you're getting medicines that are better than what we have today. I think that GLP-1s that people are taking for weight loss and things, those are showing very, very promising of reducing cravings for alcohol and opiates.
Really?
Yes, and they're going to they're studying this right now. But anecdotally, there are patients that have had alcohol use disorder, opiate use disorder, and started a GLP-1 for weight loss, and they find themselves not even desiring those things anymore.
Really?
Yes, and so I think that is looking very promising. The next thing is more contingency management. And so when it comes to, there's no medications to help people with methamphetamine, cocaine, stimulant use disorder, but there is an evidence-based study that shows great success, and that is contingency management, giving people rewards for good behavior, right? And so I think you're going to see more things come down the pipeline for that. So more more payers saying, hey, if you have a patient that says, hey, you battle with an addiction, if you come in tomorrow, your drug test is clean, an observed drug test. It's and you're clean. I hate to use that word, but let's just say consistent. We're gonna give you $5, and then if you come back the next day, we're gonna give you another $5, and so on and so on and so on until you're 6 months into this thing and you've made $1,000 because you've not used any stimulants. That has already been studied. It is well studied. It is an evidence-based practice that yields excellent results.
Really?
So I think we're going to see more use of contingency management. The last thing I would say is that there is a huge focus on social determinants of health. We know that health, home, purpose, and community are the things that somebody needs to get better. We know that social factors and social needs that are not met, if I'm worried about where I'm going to sleep tonight, I'm not talking about couch surfing. I'm talking about having stability in my life where I'm not threatened personally by violence by somebody I live with. If I have children, that they're safe, and I don't have to worry about my utility bill being turned off and that we're gonna freeze to death. If I'm not worried about that, that means I can focus on working on my recovery. So what can we do to help people get with their social determinants of health so they can be more successful in recovery? Wow. That's what I think. But I think the GLP-1s are cutting edge. I think the injection to help people have no cravings for opiates is very cutting edge. That I hope that we see here in a couple years. I think it's still in the first or second phase of clinical trials. But those are all very, very good things. One thing I wish that we could see is we like to use injectable Suboxone. And the injectable Suboxone, the one that lasts a whole month, is called Sublocade. So you don't have to take it orally. You don't have to worry about diversion. And there's one that is weekly. It's called Brixadi. It costs like $1,800 to give these shots a month. They're very cost prohibitive. But imagine the stigma that we could change if every single person walked into a facility that needed medication and they got an injection instead of pills. That law enforcement, rightfully so, is worried about diverting. Right? They're like, hey, we're worried about this, or hey, we're worried that you're trading this drug. But when somebody is getting an injection, there's injections for mental health treatment. There's injections for other morbidities that people need help with. Right? It helps destigmatize. That's such a cost prohibitive medication. But so we would love to find more ways to use injectables too.
What's one thing about Paul that you wouldn't find on your bio or resume that people may not know?
Let me think here just for a second, all right?
Sure,
Let me think here for just a second.
While he's thinking, I just want to let everybody know kind of what UC Recovery is. It's a program with the goal of making recovery possible for all. And we do that through partnerships with people like Paul and Cedar Recovery, other programs. We have a medical director, a nurse practitioner, licensed clinical social workers. But the core of our program are the certified peer recovery specialists, one in each of the 14 counties of the Upper Cumberland that are from those communities, that have the lived experience of surviving addiction and coming out the other side, who are certified through the state to help people navigate early recovery and get into the sustained recovery. And you can find out more about that at uchra.org. Or if you or someone you know is struggling right now, whether it's just looking for resources or trying to get into somewhere like Cedar Recovery, you can call 931-255-2238. Yeah.
All right. Ryan, the thing that I can think of is I'm actually on YouTube from a Bristol night race in 1992.
Oh.
My first NASCAR race ever. My
Wow.
father took me. I was 4 years old, and Davey Allison, who, God rest his soul, he died not long after that in a plane crash or in a helicopter crash at Talladega. But I am seen on YouTube very, very clearly on my dad's shoulders at my first NASCAR race ever, and I've been to over 50 NASCAR races since. I love NASCAR. It's definitely went downhill because they're too proper. I mean, we need some wrecks. We need some rubbing his racing. We need some Earnhardt's back.
Old school, right?
Old school.
Yeah.
And so, I'm a huge NASCAR fan.
Nice.
And so I don't know if you'll see anything about that, and I'm on YouTube from the 90s evidencing
wow.
this. So
I'll
1992.
have to do some digging and try to find that.
I may send you a screenshot. Don't use it against me.
Right. Well, Paul, thank you for coming. I appreciate your partnership, but I really appreciate your friendship. And
I think the world of you, brother.
yeah, thank you. And why don't you tell our viewers how they can get a hold of Cedar Recovery?
Well, the way to get in touch with us is to visit our website, cedarrecovery.com. And we're also physically located in Cookeville at 1225 South Willow Avenue, Suite 102 here in Cookeville. So people are welcome to stop by. We also have telehealth appointments available for people that need same-day appointments or people that would rather have some privacy versus needing to come into the office. But we prioritize in-person care for sure.
Well, thanks again for being here, man. And again, you can find out more about UC Recovery and UCHRA at uchra.org.